In a surprisingly short period, the concept of using food to address rising rates of chronic disease has shifted from a fringe idea to a leading policy priority of the Department of Health and Human Services under the second Trump administration. The so called food is medicine movement has been around for years, but it increased in popularity under the Biden administration and is now a significant part of the Make America Healthy Again agenda and its leader, Health and Human Services Secretary Robert F. Kennedy Jr. Today on Diagnosing Healthcare, we're discussing the evolving food as medicine landscape. Hello and welcome. I'm your host, Jessika Tuazon. I'm a partner in EBG's Life Sciences and Healthcare practice based out of our Los Angeles office. The growth of food as medicine has implications across the healthcare delivery system, including for patients, providers, payers, and investors, as well as food, beverage, and supplement companies. This episode will introduce what changes are occurring and how stakeholders can make the most of the rising momentum around food and nutrition. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Joining our discussion today is Noah Voreades, who supports OLIPOP's scientific and medical affairs partnerships. And Noah, we know you're traveling, so thank you for taking the time to join us on our podcast today.
Thanks for having me, Jessika. Appreciate and looking forward to sharing.
Great. Also joining us today is Ivan Wasserman, managing partner of Amin, Wasserman, and Gurnani. Thanks so much for joining today, Ivan.
Thank you, Jessica. Thank you, Epstein Becker Green, for hosting this podcast. It's such a great topic and a timely topic. So I'm looking forward to the conversation.
Me too. And finally, Ada Peters, who's an EBG attorney based out of our Boston office who has a background in nutrition and dietetics. Ada, it's great to have you on our podcast today, too.
Thanks so much, Jessika. Happy to be here.
Wonderful. Well, I'm so very excited to jump into today's topic. Let's get started. So, to set the stage for our listeners, Ada, can you start us off by describing what we mean when we say food is medicine?
Yeah, absolutely. So, food is medicine. It sounds straightforward on its face, but actually, when you get down to it, it's a little bit of a nebulous topic. And so, generally speaking, when we're talking about food as medicine, we're thinking about food and beverage based interventions integrated into healthcare to manage, treat, or prevent specific disease states. And where food as medicine is particularly unique is thinking about the component of being integrated into the healthcare delivery system. Public programs have a long history of thinking about food based supports, but more in a social lens. So, thinking about programs like SNAP, WIC, National School Lunch Program, National School Breakfast Program. All these programs are primarily geared at promoting food security. But food as medicine is distinct in that we're really thinking about food from a little bit more of a clinical lens, again, in the context of prevention, treatment, or management of specific disease, a little bit more analogous to a pharmaceutical product or a clinical service. And so there are several different ways food as medicine is actually applied in practice. The hallmark example is medically tailored meals. These are meals designed in concert with a dietitian and they deliver to patients home, usually for a set period of time. There's also produce prescriptions, which commonly are administered via vouchers, where there's some sort of interplay between the clinical service and then patients having authority to pick their own foods. And then there's also certainly like adjacent concepts. And so thinking about like culinary education, and then just like in any other component of the healthcare service, it's not just the widget, it's also the service that goes along with the widget. And so key to the food as medicine space is thinking about nutritional counseling that goes along with the actual food intervention. And the rise of food as medicine has grown for a lot of different reasons. The one of the leading reasons, though, is just the rising prevalence of chronic disease across the entire U.S. population, and the growing evidence around it that food and lifestyle interventions are effective tools at mitigating some of these trends, both across populations and individuals. Is also the rise of value-based healthcare and really thinking about how you can hit these holistic foundational components, generally like social determinants of health and the relationship to total cost of care and other outcomes-based metrics that a lot of value-based purchasers, payers, providers are considering. And so it's really this rise of the food as medicine space is super exciting. The tricky part is thinking about how to actually apply it into the healthcare delivery system, because food is not just like a pharmaceutical drug, device, or service. It has unique features that don't that the healthcare system wasn't designed around.
Great. Thank you, Ada. That was a helpful primer on food as medicine. Um, Ivan, could you please walk us through the types of interventions around food that Secretary Kennedy has expressed the strongest interest in since taking office?
Sure, yeah. I just have to say it's an incredibly exciting time to be a food lawyer. I've been practicing food law, FDA food law, FTC food law for over 30 years. And, within FDA, there's certainly always been a food center. F, food is the first letter of the FDA. But I can't remember a time where there's been this much of a focus by FDA, by the public, on food as there is today. Certainly pharmaceuticals and medical devices and biologics, certainly vaccines, which we're not talking about today, have been a big focus at FDA and sort of dwarfing the interest in food. But right now, because of Secretary Kennedy and the MAHA movement that's around him, food is just hot from a regulatory perspective. Like Ada was talking about, there's this feeling amongst the Maha crowd and others that food has sort of lost its way, if you will, from a health and nutrition standpoint, and there's ingredients and things in foods that people are concerned about that shouldn't be in our diet at all. But really, the focus I think has been primarily on children. So yeah, so Secretary Kennedy came in. Dr. Macri is now the commissioner of FDA, and today he was just interviewed. I saw it. He said food is going to be the focus at FDA, which is quite extraordinary if you take a step back and think about it. So some of the things that are in the news that we're all hearing about that FDA has been doing hasn't been so much as food as medicine, which is the topic of today, as far as taking food and to improve your health. The focus has been sort of removing things from the food supply that might be harmful to your health or your children's health. And the biggest ones, we've all heard about is petroleum-based food dyes. FDA wants to phase those out. They're not allowed in certain countries, and some companies are already falling in line and voluntarily taking them out before FDA is going to require you to. And actually, some states, some surprising states, Texas, for example, just signed a bill into law which is going to require warnings on food labels that have certain ingredients in them, including artificial food dyes and some other things. So that's a big deal. Ultra processed food is a fascinating one. There's a concern. There's some science. I'm not sure it's conclusive, but there is science that ultra processed food, may be contributing to adverse health outcomes. But just what is ultra processed food is FDA is going to start working on a definition of that, because I think until you have a definition of something like that, it's really hard to figure out how to create regulations around it. I've heard someone say if it has 5 ingredients, it's ultra processed. Of course, that doesn't make sense if all 5 of those ingredients are whole food ingredients. So it's going to be a lot of work in that Secretary Kennedy's focused on. Uh, Grass reform. So, taking one step back, in order for an ingredient to be in food under the current law, it either has to be approved by FDA as a food additive, which all the colors have been historically, or it has to be what's called GRAS, generally recognized as safe, which is sort of a state of being. FDA doesn't have to determine a ingredient is GRAS, and in fact, companies on their own can assemble an expert panel and determine that an ingredient is GRAS, and then go ahead and put it into foods without ever involving FDA. And Secretary Kennedy, along with FDA, are going to examine that some people think isn't putting the right checks and balances on ingredients that are being added to our food supply, if only industry is allowed to review. And I think if they're done right, they're good, but there should be some oversight, and that's what people are talking about. Um, just a couple of other things. They are looking at chemicals, streamlining what chemicals that currently are in food that are going to be reviewed. And then perhaps the most single important food product regulated by FDA is infant formula, right? So infant formula is the only food that some babies are eating. And it certainly is the most critical time of a human's development, that first year of life. And so FDA is looking at in what they've called Operation Stork Speed into possible changes to what nutrients should be allowed, what ingredients should not be allowed in infant formula, which hasn't been visited in a long time. So there's just lots of excitement right now in the food world at FDA.
Thank you, Ivan. That was a super helpful background on all of the different, things that FDA is currently looking at right now. So, policymakers from both sides of the aisle, as well as both the Biden and the Trump administrations, have been supportive of various initiatives to improve the health of Americans through diet. However, public support and insurance coverage of food as medicine benefits remain limited. Some companies like OLIPOP have been active participants in of the food as medicine movement for many years now. Noah, could you describe what you're seeing as the leading reasons why access to food as medicine benefits remain limited?
At Olipop, we've been kind of keeping a pulse on the food as medicine space, actually almost ever since we were founded in 2018. And when the Chronic Care Act of 2018 was passed, that was a very large policy and reimbursement opening for health insurance plans and health systems to think about ways to deploy healthy food at scale to their members and to their patients. And we always knew at Olipop, if we were able to hit a certain inflection point as far as a company, both from demonstrating health benefits, but also kind of consumer and social resonance, societal resonance, that we might have a place. Our CEO was a part of a lot of the conversations in the food as medicine space. We have participated in some large health insurance conferences, and just through a variety of conversations have started to really, I think, get some surface area to potentially, add some unique perspectives to the question. I think there's a few things going on. One is that the reimbursement landscape, as far as where the cost of the food as a medicine is borne, which is mainly by the health insurance plan, sometimes can actually be very expensive. So to send people meals to their home can be quite costly. And I think there's also not a very clear government framework such that a health plan can get reimbursed directly from the government for some of these services to potentially offset or subsidize the cost. If we think about the average cost of probably deploying, meals to an individual's home for on a monthly basis, it's in the several $100 range. And so for for some people where the total amount of the plan premium is a several $100 a month, that's used to cover all kinds of care for that member from, their traditional medical care to surgeries, and the like. And so adding something that potentially is going to cost several $100 a month, sometimes is just really, really challenging from a profit margin profile. I think the other element is, and that's I think is probably where the gap is closed the most, is there's a substantial amount of really incredible research that's been coming out over the last few years from some really leading universities. Tufts being an example of that, and I think they're starting to show that the ROI on food as medicine programs and the deployment of food reimbursed, either it's ultimately going to be by the U.S. government or by a health insurance plan or a health system, has some meaningful difference as far as improving health, outcomes, and then obviously having a financial ROI that I think is of importance to all stakeholders. The other element that I think a lot of people don't think about is most people that are on a commercial health insurance plan. So within kind of the commercial plans and within Medicare Advantage, sometimes you have people changing jobs. So, that means their health insurance changes potentially, or certain Medicare Advantage plans, people decide to pick one plan maybe for a year or two, and then they're offered the option to go to another plan. And so the challenge is if a health plan is deploying significant funds to send meals to someone in a food as medicine framework to either prevent a condition or to kind of remediate a condition, sometimes they're not able to get that ROI because that person is shifting sooner than they're able to see potentially that ROI from those health outcomes. Because some health outcomes, take more than a year to probably see some massive shifts. The other element is the food as medicine space. I would say up until, again, probably about 3 to 5 years ago, was largely structured through nonprofits throughout this country, whether that's nonprofits at a local or a state level. And a lot of them were tied to food banks. And so over the last 5 years, you had significant venture capital investment into this space, and that's either gone to deployment of funds for companies that are wanting to do insurance reimbursed nutrition counseling services, or, again, a very similar model as far as getting meals to somebody's door that's in need, whether there's a food insecurity issue or to kind of reverse a health issue. And so I think we're starting to see some of the changes from potentially a more of a local and nonprofit to more of a corporate. And I think, some of the contracts take time. The deal cycles in the food as medicine space with the insurance companies have very long, kind of business development and integration and execution cycles. The final thing I'll share is that, again, when we think about how is industry, responding to the renewed interest and the growing interest in the food as medicine space and the democratization of being able to get food as medicine programs into as many people's hands as possible. You have companies like Instacart, which have a significant technology layer and relationships with all retailers across the country. And so through their health business unit, they've devised some really interesting technology capabilities that work with health insurance plans or work with health systems or even individual doctors or potentially state, local, or federal government through care carts or fresh funds and some of those programs. So I think we're starting to see, industry again trying to figure out what's going to be the most approachable way to deploy basically food as medicine programs at scale that also allow for, various profitability, requirements, as well as metric reporting requirements that from what I'm understanding might become more important, as the food as medicine space evolves.
It seems that a natural way to accomplish many of the policies that Secretary Kennedy is advocating for is through increased government regulation and a stronger federal government. But doing so would seemingly conflict with this administration's ultimate goal of deregulation and reducing the so called government red tape. Ada, could you give us some thoughts on how you see Secretary Kennedy threading that needle?
Yeah, absolutely. So, as Ivan was getting to earlier, Secretary Kennedy has focused time and time again on thinking about the food supply that Americans have access to and that they're consuming. Like, what ingredients and how are those specific ingredients linked to specific health outcomes that are either positive or adverse? Um, and so, of course, the easiest way to handle that would just be like to ban all the bad things, but that flies in the face of a lot of the deregulatory emphasis of the administration, as well as the focus on consumer choice. And so, there's a variety of different ways Secretary Kennedy could thread that needle, and the first of which is just really simply, whenever possible, instead of mandates, focusing on incentives. And so, a great example of that is the secretary recently went to, a specific um, fast food restaurant in which instead of doing seed oils, the restaurant was using beef tallow. There's also a big influx in encouraging state action to take over in this way. So a great example of this is like soda or sugar bans have actually come to life. They've had this kind of resurgence of thinking about how states regulate soda or sugar, which is been a lot of times prompted by the Maha movement and Secretary Kennedy. And those are really gaining traction. So, and some of them have even been adopted. So, a rapidly unfolding situation. There's also just, he's talked a lot about the need to really lead with transparency and change food labels. And so we could see a lot of change on the food label front down the road. Um, and then also there is a lot of opportunity to think about how to loosen regulations to expand access to food as medicine, food as health benefits. So as Noah was getting at, the Chronic Care Act changed the landscape of supplemental benefits in the Medicare Advantage program. But food, generally speaking, is still relatively limited in how it can be provided as a supplemental benefit. You have to have a chronic condition in order for food generally to be provided. And so, if you expand that and allow food to be offered as to other populations of the Medicare Advantage program outside of the so-called SSBCI benefit, that would really open the doors and enable companies to and consumers to have greater access. Additionally, there's also opportunity to loosen up rules in the tax code, actually, to think about in order to enable consumers to purchase certain healthy foods that have a nexus to improve clinical outcomes through an FSA or an HSA. And again, this really aligns with a lot of the mission of this organization and really empowering consumer choice and saying, like, hey, like if you want to access certain foods, you could do so on a pre-tax basis in certain limited situations. But right now, the opportunity to do that is very limited, but it could really be expanded and open the door to increase access that's separate from the Medicare, Medicaid, commercial, bifurcated cover insurance coverage landscape.
And Jessica, if I could just add one thing, dovetails with what Ada just shared. I think also, again, when we think about the mechanism by which, and Ada alluded a little bit to this. When we think about the mechanism by which plans have the not only probably the legal or regulatory latitude, but the reimbursement optionality for food as medicine, I think part of the limitation that she just mentioned is also due to how potentially CMS or other bodies that kind of regulate how food as medicine is integrated into a plan and potentially how it affects certain metrics by which this is most applicable typically in a Medicare Advantage, population sometimes, but some of these metrics um, can influence a plan's profitability. And there's not really, the metrics that go into some of these plans are not intimately tied to the deployment of food having a measured beneficial outcome. And so there's kind of this gray zone of when food is able to be provided to a member, what members can be provided food, and there's just also I think none of this reporting mechanism back to show the ROI that we're seeing in kind of peer reviewed science or potentially collaborations, very small pilot studies with even health insurance plans, is not kind of integrated into, um, the plan policy and kind of reimbursement structure.
Great. Thanks, Ada and Noah. So we've talked a little bit in this podcast already about supporting consumer choice through more transparent food labels. Ivan, I'd love to get your take, on what are some of the high-level guardrails for companies with respect to labeling and marketing of their foods for health benefits, and what changes are under consideration right now at FDA regarding health and nutrition claims.
Yes, so obviously we want consumers to eat foods that are medicine. We want consumers to eat healthy, but consumers have to know, right? Consumers have to know and understand and be told what foods are good for them, what potential health benefits an individual food has. So, how do you communicate that information to consumers? Obviously, FDA and the government and the health pyramid and all that is a good way. And that's sort of on the macro level of nutrients and different types of foods that people should be eating. But, my world primarily is, how can CPG food companies communicate their health benefits, their to consumers, or their lack of harm, I suppose, either way. They're somewhat hamstrung under the law, rightly or wrongly. So foods in the United States cannot claim to treat, cure, or prevent a disease. Doing so makes them a drug. So, when you think of medicine, typically you are thinking of a substance that will treat or prevent a disease, although not necessarily. And so your consumer product companies are somewhat limited in what benefits that they're allowed to speak to the product under the current law. I don't see that changing. That's been the definition of what's a drug versus what's a food since I'm going to maybe say this wrong, but 1906. I don't see a dramatic shift in that happening anytime soon. While foods cannot claim to treat, cure, or prevent a disease, they can claim to, quote, affect the structure or function of the body. So health benefits about supporting normal bodily functions are allowed. It's the category of functional food. You are certainly allowed to make those claims. Some easy examples is calcium supports strong bones. Protein helps build muscle. Uh, I'll say one that's near and dear to my heart and perhaps Noah's. Fiber supports healthy digestion. OLIPOP is a functional food product that's got a lot of fiber, and they're allowed to claim not only that it's high fiber because it does meet that FDA definition, but also that it does support healthy digestion through the prebiotic fibers. So companies in the CPG space might be very excited about food as medicine under Secretary Kennedy, uh, but they still have significant guardrails. And we were concerned there was a lot of layoffs, which people might have heard about at FDA. A lot of staff changes, different leadership has changed. We were a little bit concerned, I suppose, if it was going to become the wild west of food claims. Can our companies just going to say whatever they want because RFK prefers food to pharmaceuticals, and there won't be much FDA enforcement? But in our practice, we haven't seen a slowdown in FDA enforcement against companies making improper claims for their food. So you got to be very careful. Not only that you have the right science, of course, to support your health benefit claims for any kind of CPG product that you're selling and you're making health claims for, but also that you're complying with the FDA rubric, which I think is not going to change dramatically anytime soon. There have been some initiatives that have been started. Actually, the front of pack labeling is an interesting one that was started under the Biden administration, and it's continued where at some point there may be mandatory front of pack labeling about added sugars and some dangerous ingredients that are going to be in their product. You can certainly currently now talk about beneficial nutrients and, like I said, make structure function claims in your product. So food as medicine, as a food labeling lawyer, I get a little nervous when I hear that term. But I do think that there's great opportunity out there, and we'll talk a little bit more about potential changes, I think, coming up.
Great. Thank you, Ivan. Today's discussion overall about food as medicine has been so informative. And to close out today's roundtable, I wanted to dig in a little bit more about where everyone thinks we may be headed in the coming months and years. So, just to open up the floor, do you have any final thoughts on how you see HHS contributing to the food as medicine movement going forward, particularly under the leadership of Secretary Kennedy? Ivan, you can go ahead and start that discussion.
Thank you. Thank you. That's been a great discussion. I think we should probably just set a date, pencil in a date for the three of us to get back on a podcast, maybe in 2 years, because I think there's going to be a lot of exciting changes. And one thing that I think I'm not sure I've heard specifically FDA or Secretary Kennedy talk about, but the one exception to everything I just said before about foods is you can make a health claim if it's authorized by FDA. And a health claim under the FDA rules is a claim that characterizes the connection, the relation between a nutrient and the reduction in a risk of disease. So you're allowed to make that claim if you petition FDA and if they authorize it. There's a bunch of authorized health claims out there. I mentioned calcium and strong bones as a structure function claim, but you can mention that calcium prevents osteoporosis, which is a disease because FDA has authorized that claim. There's claims you can make about the connection between fruits and vegetables and heart disease, et cetera, et cetera. I do think that there might be, and FDA, I should say, has been very strict about granting those claims, requiring an extremely high level of scientific agreement on those claims. And you can make qualified claims, but that's a sort of story for another podcast. But I do think that there might be an opportunity for companies that have been sitting on the sidelines thinking, or companies or industries, I should say, that have been sitting on the sidelines thinking, FDA is never gonna grant this health claim, that this might be an opportunity since RFK and FDA are so focused on food as medicine, really. It might be a good opportunity to start thinking about gathering the right science, putting it all together, and submitting more petitions for health claims to really get actual food as medicine claims out there.
Thank you. Ada, do you wanna have any thoughts you'd like to share?
Yeah, absolutely. So, I mean, taking a step back, I mean, the idea of food as medicine from a high level concept is something easy for all of us to wrap our head around. We're all humans. we all eat every day. We all feel the power that food has in impacting our life, and it's not a stretch to say that we all at some level can feel the link between food and medicine and health. Again, the really tricky part is thinking about how does food interact and embed itself into the healthcare delivery system, and that's really where the federal government and the both Congress and the executive branch have so much sway in making that transition possible, for companies and providers and patients to come in and scale so that access can be more universal. And so, the quintessential way that could be done is creating clear reimbursement pathways. There's certainly been in the food as medicine space a sizable focus on the reimbursement landscape around legislation. But there in that, of course, specifically legislation around Medicare. And generally speaking, when Medicare something covers an item or service, a lot of other payers follow suit. It's a pretty high bar to think that would happen. Certainly, we can all dream and wish and hope and take steps to make that possible. And so we spent a lot of time talking about supplemental benefits here. One of the key ways to do that is through supplemental benefits and in the Medicare Advantage program. And this is real right now. It's, as I was saying before, it's limited to Medicare beneficiaries with chronic conditions. If you open that up to broader populations as a standard traditional benefit, you can really enable food to be used on a much more widespread way, specifically in the context of prevention, which arguably has so much power in that space. And it could be a situation where Medicare Advantage plans really have the opportunity to figure out how food as medicine really fits, from a clinical and cost standpoint, and then other payers can use the innovation to follow suit, and maybe even Medicare can adopt, can take the lessons learned into its own program in a traditional fee for service landscape down the road. And I was saying before, there's also certainly opportunities to change the tax code. And whenever we think about reimbursement, each one of the reimbursement categories, particularly in Medicare, has certain like evidentiary standards. And so for Medicare Advantage, for instance, it has to be primarily health related. And so there's also a lot of need that the federal government could come in to really think about building that evidence base to, of course, think about how food can be optimized in a clinical context, but also how it can fit in to reimbursement, the reimbursement case down the road. And so when in building that evidence base, one of the key tools is actually creating billing codes. And so billing codes have this double prong benefit is that one, CMS generally creates billing codes, called HCPCS codes for drugs and devices, and then other payers take that code and they use it and they embed it into their systems to so it has this sweeping market impact, the billing codes created by CMS. And then not only does it enable the framework for reimbursement, it also enables the framework for evidence and um, claims-based analysis. So you can look and say, okay, this intervention was provided here, it impacted total cost of care this way, and then from there you can have payers and academics and everyone can draw conclusions that they use to enhance and move the movement forward.
Really enjoyed this conversation, so thanks for providing all of us the forum. I think when we think about the food as medicine space, I think what we've realized at Olipop is in talking to various stakeholders is everyone just thinks of food. And while food is critically important, one thing that we know when we look at, epidemiological data around nutrition patterns and, large dietary patterns, that the majority of added sugars in the American diet is coming from sugar sweetened beverages. And so we can give people all of the healthy food, but if they're also still consuming, the majority of their added sugars or things that obviously people within the food as medicine space want to mitigate, reduce, and prevent from being in abundance, we have to provide healthy beverage options. And I think just telling people to drink water is not something that's going to work, right? We need to have approachable fun, delicious, but also nutritionally dense solutions like OLIPOP. So I think what we need to think about when we think about the food as medicine space is not to just think about food, but to think about what are some other options besides water that we can provide millions of Americans across all different programs, whether they're government or private within the food as medicine space. I think the other thing that's really important is, as we're starting to think about what's going to be the policy or what's going to be the commercial reimbursement landscape, to involve industry in some of these conversations. So to start to think about how are better for you brands, providing second order or third order effects to how people are holistically thinking about their health and their food and nutrition choices. Having a crystal ball, I think, is hard. And so I would just lastly hope that we are going to have some openness in the FSA, HSA kind of rules to what, Ada alluded to. I think that's critically important. And I think that's critically important for a few reasons. One is that, there's within the HSA, wallets alone in America, there's billions of dollars that are there that could be deployed to purchase healthy, food and beverage products that maybe are going to have some beneficial economic impact as far as increased spending and taking some of those funds that are basically kind of locked up because there's such limitation and being used towards purchasing things that a consumer has been probably wanting to do all along. Um, the and I think along the lines of the HCPCS code, I think what would be really incredible is, when you look sometimes at the reimbursement for, functional food and beverage products that have a HCPCS code, sometimes the amount of money that is allowed for a health plan to reimburse for that item is actually very low, and it limits, innovative brands, that have innovative solutions that can, have human health impact at scale from being able to be a part of that. And it allows for more, health forward, health force multiplying options to be used. So those are some of the things that I hope that we'll see in the future, and will allow more of the food and beverage space that's doing the right thing to have impact. The final thing I'll share is that when you look at a lot of consumer trend data, particularly from the new consumer trends report done by Dan Fromer, it's interesting how younger populations, Gen Z and millennials, actually have reported, from my understanding and looking at some of the data that he's put out, that they would prefer to look for a plan that's going to provide them with a food as medicine benefit. And so maybe seeing a food as medicine benefit not as a cost center, but as an investment and a retention center, could kind of flip the thought process around plans, and could, as I alluded to, one of the challenges I think with deploying food as medicine at scale is potentially people, the retention issue with plans, people switching plans. And so to the extent that it could keep people with the plan, could, create a stronger kind of brand affinity for a health insurance plan. And sometimes health insurance plans, unfortunately, don't have the highest NPS scores and, kind of customer loyalty. So potentially thinking a little bit outside the box as far as the younger demos that are going to be moving into, you know, you have millennials that are probably over the next, 10 to 20 years are going to be aging into the Medicare population. And so to think about how starting them on kind of this food as medicine mindset, giving them the funds to do that is going to potentially set us all up for lower total cost of care overall and lower the total healthcare burden. So I think thinking ultimately what the consumer wants and making it a little more consumer approachable is going to be beneficial.
Well, thank you, Noah, Ivan, and Ada, for taking the time to participate in today's discussion on food as medicine under Secretary Kennedy. And thank you all to all of our Diagnosing Healthcare listeners. I'm your host, Jessika Tuazon. If you like what you've heard today, please don't forget to subscribe. Diagnosing Healthcare is available wherever you get your podcasts.
This podcast is presented by Epstein Becker and Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.